Good morning. Today we're going to be talking about Chapter 10 and blood and circulatory system disorders. And so first we want to talk about basically what is the circulatory system and why is it important? Well, our heart is obviously the center of the circulatory system because that's going to be what pumps the blood so that it gets to all of the areas of our brain from our ears down to our tippy toes. And so we're going to be talking about that, the vasculature, and a lot of other really cool things. So the circulatory system itself consists of the cardiovascular system as well as the lymphatic system. And this chapter is going to be covering the blood vessels, the blood, and associated disorders, as this is a pathophysiology class. So here is the anatomy of the major arteries, and this is figure 10.1 on page 186 of your book. And so you can see that obviously they go all the way from your head to your toe because if something's not vascularized, more than likely it's going to die in your body, right? So you have your cerebral arteries, you have the brachial arteries, and you have the other, you can see obviously in the book, but you have, the renal arteries, the external iliac, the femoral arteries, so all of those. We also have now the anatomy of the major veins, and this is on page 187 in figure 10.2. So this one, there is a little bit of a demarcation. Here you have the deep arm veins, and those would include the subclavian vein, the profunda brachial vein, the brachial vein, radial, the ulnar, all of those. Then you also have your deep leg veins, and those are the ones that are going to be isolated to the leg. And over here you have your superficial arm veins. So you can say you have deep veins, and then you also have your superficial arm and leg veins as well. And again, that's on page 187. So, for blood vessels, what we do is we separate them from basically arteries to veins, right? And so arteries all the way down to your arterioles, these are going to be transporting blood away from the heart, where your veins are going to be the ones that are going to be returning blood back to the heart. And so, as a general rule, arteries are going to be thicker walled and stronger because they have to deal with more pressure, right? So if you think of the pumping um, strength of the heart, and it has to go everywhere, right? So the arteries have to be very strong to withstand that so that they don't blow. Where the veins, you kind of have a return pressure, so that one's not going to, I mean, obviously there's still pressure there, but it's not going to be as much. So that's why when they take blood from you, usually they do it from your vein, because then if you accidentally let go, it's not going to squirt everywhere, right? So your arteries all the way to your arterioles transport, again, blood away from the heart, where the veins and the venules return it back to the heart. And you also have your capillaries, and these are like our little baby vasculature. And so these are going to be letting us do the microcirculation that occurs within the tissue. And we also have systemic circulation, and this is where we have the exchange of gases, nutrients, and wastes within the tissue. And then we have a very important pulmonary circulation, and this is where all the magic happens. So this is where we have the gas exchange to get rid of the carbon dioxide and attach the oxygen, and this occurs in the lungs. So looking at the structural comparison of the arteries versus the veins, this is figure 10.3 in your textbook on page 188. And so again, you can see the arterial walls here are thicker and the veins have a thinner wall, okay? Then you have veins will have valves in them. You have the elastic membrane. Again, that's going to be thinner in veins because it doesn't have to deal with as much pressure. Then you also have some connective tissue that is present in both arteries and veins. And you can see here it looks like it's a H&E stained tissue, that the vein has a larger diameter of it and a thinner wall, where the artery has a thinner diameter and a thicker wall, again, due to pressure. And again, this is going to be another stain showing the same exact thing. So the histology of arteries and veins, you have the tunica intimata, and this would be the endothelial cells. And these are composed of your simple squamous epithelial cells. So go back to your anatomy and physiology, basics, where we have to remember the difference between the squamous cells, cuboidal cells, etc. You have your tunica media, and this would be the middle layer, and this is composed mostly of smooth muscle. Then you have your tunica adventia, which is your external, and this is composed of connective tissue with fibrocytes, collagen, specifically type 1 collagen, and elastic fibers. Again, if you ever get stuck, look for your root words. Okay, media sounds like middle, medium, right? Media is the media of the road, median of the road, right? Intima, that's the internal, right? And then the adventura. So it's like, again, I always really stress root words because that's going to be what's going to help whenever you're stuck. So moving on to an overview of the blood. Why do we care and why do we have it? Well, the blood is, its major function is to transport oxygen and nutrients to all tissues. We also use it to remove the waste products in cellular metabolism, or of the cellular metabolism that's occurring to keep us alive. And it also plays a critical role in the body's defenses in the immune system, as well as serving to maintain our body homeostasis. So remember, we always want to have that homeostatic level of everything, pH, electrolytes, fluid, etc. And so your blood system has a major component in all of this. So when we look at the composition of blood, we have the plasma and we have the cellular component. And this is detailed on page 187 is where it starts. And so your plasma is going to be the clear yellowish fluid that remains after the cells have been removed. And these are plasma proteins, where your cellular components are going to be the erythrocytes, the leukocytes, and the thrombocytes, or the platelets. And so you can look and see, and you can see this as things are, as you like spin out blood, you separate it from the red cells to the white serum. Hold on a second. Okay, so now on to the components of blood and their functions, and this is found on page 189 of your textbook. So on the top here, we have the cellular components, and this contains the blood, which is the cells of the formed elements, and that's about 45% of it. You have your cells in this little bracket, including your leukocytes, your erythrocytes, and your thrombolytes. And your erythrocytes here in the middle include your hemoglobin, which transports oxygen, and your thrombocytes are down described over here, and those are your blood clotting factors. In your leukocytes, we have a subdivision of granulocytes and agranulocytes, and these can be broken down, and again, here are their functions listed. Where in the fluid components, plasma is about 55%, and of that we have proteins, water, and other. The proteins include albumin, globulins, fibrinogen, and others, and those are going to help regulate the osmotic pressure of the blood, the antibody presence of the blood, our blood clotting factors, etc. The water itself is going to help transport and exchange the bodily fluids and secretions. And then the other down here includes your amino acids, your carbohydrates, your lipids, hormones, enzymes, electrolytes, and wastes. And these are all coming and stemming from cellular metabolism. So again, this is figure 10.4 of your book on page 189. Hemipoiesis. This is basically the birth of new cells. And so this is on page 190 in your book, figure 10.5. And so up at the top, you have your hemocytoplast. And then these are going to branch down into these 5 subcategories, which then continue to branch down, and in the end you end up with having your erythrocytes formed, your granulocytes, which include these 3 cells, basophils, eosinophils, and neutrophils, and then your agranulocytes, which include these 2 cells, which are your lymphocytes and your monocytes. These 5 together group to make up your leukocytes. And then over here you have your platelets. Sorry. I tried to pause, but apparently that didn't work. Okay, so what are your erythrocytes? These specifically are your red blood cells, and these are bioconcave flexible discs. Those are fancy words for saying they look like donuts. The erythrocytes have no nucleus in the mature state, and they do contain hemoglobin, and hemoglobin, when you break that down, includes the globulin portion as well as the heme group. And hemoglobin is the transporter of oxygen in our body. The lifespan of a red blood cell is approximately 120 days, and the erythropoietin is produced in the kidney, and then this is going to stimulate the erythrocyte production. So again, your body is just one well-oiled machine that really works together to make everything happen. So this is a picture of our donuts, or our Cheerios looking cells. These are actually your red blood cells. And this is figure 10.6, and they're showing your normal bioconcave, non-nucleated red blood cells. And so, basically, yeah, they're fun. They're donut shaped. They're kind of squishy. So as they're trying to go through your capillaries and stuff, actually, this is a fun little fact. Red blood cells, their size is about 8 microns, and our capillaries themselves are about 8 microns as well. So sometimes the red blood cells, 7 to 8 microns, they have to like squish up a little bit to go through your cells, your very, very, very small cells. All right, so this here is a picture of your normal blood cells, and this is on page 191. And so if this is figure 10.8, so you have your normal blood cells, and note that there are many erythrocytes, and that would be the purple guys, and then the discs themselves are bioconcave, and they have faded centers because they're thinner in the center. The nucleocytes, I have a larger size with the nuclei, and again, those are the ones that are stained purple, and there are various types shown in this picture. And then you also have the thrombocytes, and those are the small dark pieces that are kind of look like just litter, but they're not. Okay, so that's what a normal blood cell culture would look like. All right, so when we talk about the breakdown of hemoglobin, this is figure 10.7 in your book on page 191. So basically you have your hemolysis of the erythrocyte. And so again, break it down to your root word. To lyse means to break apart. Hemo means blood. And so basically the spleen and the liver remove old or damaged cells. And remember, the blood cells last about 120 days. And so when we break them apart, then it breaks down to the hemoglobin, and we can break off the heme group and the iron group. And the iron is going to be recycled back to the bone marrow to be either reused or stored. And then your heme has your bilirubin, and this is going to be unconjugated, and it's transported by being bound to the serum albumin. And then this goes into your blood, and then it goes into the liver, where it's going to be conjugated or kind of stuck with the glucuronic acid, and then that forms our conjugated bilirubin, and then that goes down into the bile. Okay, and then you also have your globin, and these are going to be broken down into the amino acids and be recycled. So basically, our body is very good at recycling everything, and so it's going to break things down and get them back to a normal like base product, sorry, so that we can reuse them again. So for blood clotting, again, we want to try to maintain hemostasis. And so we don't want to have uncontrolled bleeding in our body, because that would not be good. So there are 3 different steps to blood clotting, and these would be the vasoconstriction or the vascular spasm that occurs after the injury. And then the platelet is going to clot, and then the coagulation mechanism is triggered. And the plasmin will eventually break down the blood clot. So basically, this is on page 192 of your book. And so your 3 steps, again, here are there. And so you have the first immediate response of the blood vessel to the injury is vasoconstriction or the vascular spasm. In the small blood vessels, this decreases the blood flow, and it may allow for a platelet plug to form to stop the bleeding. Second, second is thrombocytes tend to adhere to the underlying tissue at the site of the injury, and the blood vessel is small, can form a platelet plug to, again, plug the bleeding in the vessel. And then third, if the blood clotting or coagulation mechanism is required by larger vessels, by which the clotting factors are present in active forms in the circulating blood, are activated through the sequence of reactions that are shown in figure 10.9, which is what was the original, or the figure on the previous slide. And then evidence indicates the additional overlap in favor of activity between the intrinsic and extrinsic pathways, but the cascade of reactions is the basis for coagulation. Right? So what about clot formation? And clot formation is discussed on page 193. So you first have the production. So the clot formation requires a cascade of events as summarized. First step is that the damaged tissue and platelets are going to release the factors that stimulate a series of reactions involving numerous clotting factors, and these finally produce the prothrombin activator, which is also abbreviated PTA. Then the second step would be that prothrombin, or factor 2, which is inactive in the plasma, is converted into thrombin. And then the thrombin is a multifunctional molecule that functions both as a procoagulant and an anticoagulant. The third step is going to be fibrinogen, which is also known as factor 1, is converted into fibrin threads through the action of thrombin. And so then the next step is where a fibrin mesh is going to be formed to trap the cells. And basically think of like beavers build dams, right? So this is kind of the same thing. It's going to make up a solid clot or a thrombus, and therefore it's going to stop the flow of the blood, and that's shown in figure 10.10. And then the last step is that the clot is gradually going to be shrinking or retracting itself, and by doing that, it pulls the edges of the damaged tissue closer together, therefore sealing the site. So it's just kind of a very cool work together process. So what about hemostasis and anticoagulant drugs? This is figure 10.9 on page 192 of your book. And so you have calcium that's required. You have your intrinsic pathway, which is activated by the endothelial injury of the blood vessel. And you have all these factors that come together and they merge down here where it's going to be factor X, which is going to be converted into XA. You also have your extrinsic pathway, and this is activated by the tissue and platelet injury. And this starts out with the tissue thromboplastin 3A, and that goes down here and is converted into 7. But all of these calcium is going to be required. And then when we converge, down here we have the process of phospholipids. That is going to be the commonality between the two different pathways. And that is going to come in here and cause the prothrombin activator to be activated. And then we have the prothrombin that turns into thrombin, fibrinogen turns into fibrin, and then the insoluble clot formation that it forms. So this is basically what we just talked about, and now what the medical or the meds do. So basically, if you use oral anticoagulants such as warfarin, how warfarin acts is it's blocking the synthesis of prothrombin here. And so if the prothrombin is not made, then obviously we can't continue down the pathway to have clots form. Vitamin K is required for the synthesis of this. Over here, heparin blocks the sequence of thrombin being made as well as fibrin being made. You have over here in the blue the natural fibrinolytics like antithrombin 3, protein C, and plasmin, and they're attacking these different pathways of this thing of this pathway, right? And then also you have your thrombolytics, which are your TPAs or your clot busters. For example, streptokinase is one, and this would be what we would use for strokes, right? When you do clot busters or TPA post-stroke to try to bust up that clot and reverse any damage. And then you also have over here where ASA can block the platelet aggregation. Therefore, platelets wouldn't be able to come together to form that fibrin clot. So again, that is on page 192, and it's figure 10.9. So what about blood typing? So blood typing is going to be talked about on page 193, and this is based on antigens in the plasma membrane of the erythrocytes. You have the ABO system, and this is based on the presence or the absence of specific antigens in the body. These antibodies are found in the blood plasma. You also have the RH system, or the RH groups, and this is antigen D in the plasma membrane. If there is antigen D in the plasma membrane, then this would be an RH positive factor, where if there's the absence of the antigen D, then this would be RH negative. So looking at our blood groups, this is 10.1 in your book. You can have blood type group 0 or O, 0. Oh my gosh. Type O blood. right? And then this means that you don't have any RBC antigens, and you have the presence of both anti-A, anti-B antibody plasmids, and for transfusion, they can only receive O. That's the universal blood type. Okay, you can see the blood group A has A antigens, and they have anti-B, which means if they received B blood, then they would attack it, and it would cause a lot of problems. Same with B. AB is blended. Okay, so this is just the compatibility and who can have what. So what about diagnostic tests? This is on page 194 in your book. The first one that we do a lot is the CBC, and this stands for complete blood count. And this includes total red blood cells, which are RBCs, white blood cells, which are our white blood cells, WBC. I'm just Johnny on the spot today, guys, as well as our platelets. We have our leukocytosis, and this would be caused by increased white blood cells, and this is associated with inflammation or infection. You can have leukopenia, and this would be decreased white blood cells, and this is associated with some viral infections, radiation, and chemotherapy. Then you also have increased eosinophils, and this is common in allergic responses. You also have differential blood counts that can occur to just figure out the different types of the cells that you have in your blood. So what about morphology? So morphology is going to be how things look, right? So I kind of think of like, I don't know, Transformers used to morph into something. They changed shape. They changed the look of things. So morphology is like how things look. And so how we can look at morphology of blood cells is in blood smears. And so this is going to show the size, the shape, the uniformity, and the maturity of cells. And these different types of anemia can also be distinguished by the morphology of the blood cells. You can also do hemocrit, and the hemocrit is going to be showing the percent of volume of cellular elements in the blood. Um, like for instance, a low red blood cell count may be an indicator of anemia. Your hemoglobin is measured, and the amount of hemoglobin per cell is shown by the mean cellular hemoglobin, and the MCH, which is included in this VC, is going to be the oxygen capacity, carrying capacity of the blood. You can also count for reticulocytes, and this is basically assessment of the bone marrow function. And what reticulocytes are immature non-nucleated red blood cell counts. And so you can also do chemical analysis, and this will determine the serum level and components such as iron, vitamin B12, folic acid, cholesterol, urea, as well as glucose. You can also measure bleeding time, and so this will measure the platelet function and how well they're functioning in your body. And you also can measure the PT time, which is the prothrombin time, and this partial thromboplastin time, which is PTT. And this measures the function of various factors in the coagulation process. And we have an international normalized ratio, and that would be the standard version. So basically, on page 195, it says blood clotting disorders can be differentiated by tests such as bleeding time, which again, the bleeding time measures the platelet function, which is the time to plug a small puncture wound. The prothrombin time, or the international normalized ratio, and the INR measures the extrinsic pathway. The partial thromboplastin time, and that measures the function of various factors in the coagulation process. And so they're all used to monitor anticoagulant therapy, and the reference values for these tests are best established by individual patients based on their health history. So again, that's on page 195 of your book. So what about blood therapies? Again, this is discussed on page 195 of your book. You have whole blood, packed red blood cells, and packed platelets. And basically for severe anemia or the thrombocytopenia is what we would be wanting to do this type of therapy for. He also has plasma or colloid volume expanding solutions, and these are used to maintain blood volume. So these can be administered without risk of reaction because they're free antigen and antibodies, and they help in balancing osmotic and hydrostatic pressures. You also have artificial blood products, and these are available, but none can perform all the complex function of normal whole blood cells. They're compatible with all blood types, which is great. One example of it would be Hemolink, and this is made from human hemoglobin, whereas Hemopure is made from cow hemoglobin. Oxygen is synthetic and genetically engineered blood substitute, and other agents such as MP4, which is undergoing clinical trials, is used to combine with blood to improve the oxygen transfer from red blood cells to tissues. So although promising, none of them have been approved from the United States Food and Drug Administration yet. So basically, there's no substitute for the original, but we're getting close. Okay. So when we're talking about some of these specifically, epopoietin alpha, which the trade names would be Procrit or Eporix. This is a form of erythropoietin. This is produced through the recombination of DNA technology. It can be used by injection to stimulate the production of red blood cells in certain surgical procedures, for instance, like a hip replacement. And for patients with anemia that's related to cancer or chronic renal failure. And this is really cool because it reduces the risks of infection or immune reaction with multiple blood transfusion. We can then have bone marrow or stem cell transplants, and these are used to treat some cancers and some severe immune deficiencies or severe blood cell diseases. A close match in tissue or human leukocyte antigens, which is the HLA type, is required for success. And the marrow stem cells are extracted from the donor's pelvic bone, filtered, and then infused into the recipient's vein. And normal cells should appear within several weeks. And in cases of malignant diseases, cancer, pretreatment with chemotherapy or radiation is required to destroy tumor cells before the transplant. We also have drug therapy, and basically these are for patients that are suffering from a lack of blood clotting capability. And so these are going to aid in the clotting process. We have approved N-plate to directly stimulate the platelet production by the bone marrow. Novo-7 is a drug that's developed primarily to treat hemophiliacs, and it has been adapted for use in treating combat trauma. And although these drugs are in use today, unintentional clots that may form during their use continue to be a dangerous problem that must be closely monitored. And again, that's on page 195. What about blood diacresias? And so this would be like your anemias, your different types of anemia, like iron deficiency anemia, B12 deficiency anemia, and aplastic anemia. So a whole bunch of these other disease, hemolytic anemia, etc. So what is anemia? Well, anemia causes the reduction in oxygen transport, and this basic problem is the hemoglobin deficit. And oxygen deficits lead to less energy production in all cells because cell metabolism and reproduction is diminished. Compensation mechanisms can occur, and these include tachycardia, so a rapid heart rate, and peripheral vasoconstriction. And general signs of anemia can include fatigue, pallor, which is a pale face, dyspnea, and tachycardia. And so dyspnea means increased effort to breathe, so it gets a little bit harder to breathe. The oxygen deficit can lead to decreased regeneration of epithelial cells. And so because of this, the digestive tract becomes more inflamed and ulcerated, and this can lead to stomatitis. And this can also cause inflamed and cracked lips, and this can also cause dysphagia, and hair and skin may show degenerative changes as well. So severe anemia may lead to the angina, which is chest pain, or congestive heart failure as well. So with the iron deficiency, specifically, insufficient iron impairs the hemoglobin synthesis, or the making of hemoglobin. And so you have microcytic, hyperchromic red blood cells, and these result in low hemoglobin concentration of cells. This is very common, and the ranges can be from mild to severe. It occurs in all age groups, but it's more common in women of childbearing ages. It's estimated that 1 in 5 women is affected, and the proportion increases for pregnant women. And frequently, this is a sign of underlying problems. So you just kind of want to keep an eye on it and figure out what's causing it. This is a blood smear of a iron deficient anemic person, and so this is figure 10.12 in your book on page 196. All right, so causes of iron deficient anemia, they can be dietary intake of iron below the minimum requirement, chronic blood loss, such as from a bleeding ulcer, hemorrhoids, or cancer, impaired duodenal absorption of iron, and so basically your GI system's not absorbing what it needs to be absorbing. And in many disorders, there's also malabsorption syndromes that are underlying causes. It can cause, or if you have severe liver disease, it may affect iron absorption as well as storage, so therefore causing anemia. Signs and symptoms can be pallor of the skin and the mucous membranes, fatigue, lethargy, and cold intolerance. It can also cause irritability, degenerative changes, stomatitis and glossitis, menstrual irregularities, delayed healing, as well as that rapid heart rate, heart palpitations, dyspnea, or syncope. So moving on to precocious anemia, and this is on page 197. The basic problem is a lack of absorption of vitamin B12 because of a lack of the intrinsic factor. And so the intrinsic factor is secreted by the gastric mucosa, and it's required for the intestinal absorption of vitamin B12. This is characterized by very large, immature nucleated erythrocytes, and these carry less hemoglobin, and they have a shorter lifespan. The cells. It can be from a dietary insufficiency, but that is very rare. Usually genetic factors have been implicated, so it's more common in light-skinned women of Northern European ancestry, and often it accompanies chronic gastritis, so stomach problems, right? And it may also be the outcome of gastric surgery. So how does this develop? Well, this is figure 10.14 in your book on page 198. And so over here you have normal erythropoiesis. So in step 1 here, it's small, so I suggest opening your book. And vitamin B12 is food, and then the parietal cells and the gastric glands over here secrete the intrinsic factor into the stomach, and those are the little blue circles that you would see in the figure. Then step 3, vitamin B12 binds with the intrinsic factor in the stomach, and then vitamin B12 intrinsic factor complex is absorbed from the ileum, and the B12 is transported into the bone marrow of the cell, or of the bone. Step 5, vitamin B12 promotes the maturation of erythrocytes, and then 6, the normal erythrocytes are going to be in the circulating blood. Now, over here in B, if we have a vitamin B12 deficiency, well, we'll still ingest the B12 in the food, but down here, the antibody reaction causes the atrophy of the gastric mucosa, and so that means that basically there's no presence of the intrinsic factors in the stomach. And then in step 3, because we don't have those intrinsic factors in the stomach, we can't absorb the vitamin B12 in the ileum. And then the vitamin B12 is then going to just be excreted because we can't absorb it. And then that causes a lack of vitamin B12, which then is going to cause the bone marrow to produce megaloblastic erythrocytes. So that's how it can develop. So what about vitamin B12 and nerve cells? Well, B12 is needed for the function and maintenance of neurons, and significant deficit of the vitamin will cause symptoms in the peripheral nerves, and these may be reversible. So here's figure 10.15 in your book, and this shows a vitamin B12 deficiency with macrocytes and a neutrophil with the hyperpigmented nucleus in the peripheral blood smear. All right. Additional manifestations of this B12 deficiency can be that the tongue is typically enlarged, it's red, sore, and shiny. You can also have digestive comfort, and often this is with nausea and diarrhea, and you also can have feeling of pins and needles and tingling in the limbs. how do we diagnose this? Well, um, this is on page 199. So first of all, you would do microscopic examination of the erythrocytes. So the erythrocytes appear as macrocytic or megaloblastic and nucleated on the microscopic examination, and they're reduced in number in the peripheral blood. The bone marrow is hyperactive with increased numbers of megaloblasts, and the granulocytes are hypersegmented and are also decreased in number. And also the vitamin B12 levels in the serum is low. They're low, and they'll do a Schilling's test. And this is where an oral dose of radioactive vitamin B12 is used to measure the rate of absorption. Also, you can have the presence of hypochlorhydria or achlorhydria, and this confirms the presence of the gastric atrophy. So moving on to sickle cell anemia. This is on page 200. So it is an autosomal disease. It expresses incomplete dominance. Anemia occurs in homozygous recessive fashion, and diagnostic testing is available to figure out if you have sickle cell anemia. More common in individuals of African ancestry, and this is heterozygous condition, which is somewhat protective against malaria. So you trade one sword for the other, right? So you can be predisposed for anemia, but you might have a lower chance of getting malaria. 1 in 10 African Americans is heterozygous for that trait. Looking at the genetics of sickle cell anemia, this is figure 10.18. And you can see doing your Punnett squares like we have before. Then when we have a parent with sickle cell and we have a normal parent, then you would get a 50% chance for the child with sickle cell trait. If you have parent with sickle cell anemia itself and a normal, then you have 100% sickle cell trait. And then if you have a parent with sickle cell trait crossed with a parent with sickle cell trait, then you would have 25% of your children would be normal, 25% would be having sickle cell anemia, and 50% would have that trait. So again, from those Punnett squares, set them up and then carry the top down and then the side over and then interpret with using the key. We covered this a few lectures ago, or else I'd go into more detail. So basically with sickle cell anemia, you are going to have the abnormal hemoglobin. You can also have the sickle cell crisis that can occur whenever the oxygen levels are lower, and this can cause altered hemoglobin, and that altered hemoglobin is going to be unstable and change shape and hypoxemia. You can also have sickle cell cells that are too large to pass through the microcirculation, because remember, we're talking 8 microns, which is about the width of a hair, or like if you put a hair in, your hair itself is about 8 to 10 microns. So you're talking really small. And then also this obstruction can lead to multiple infarctions and areas of necrosis. So looking at this picture, this is figure 10.16 in your book on page 201. This is going to be the structure of hemoglobin. It is a multi-subunit protein, so this actually has a quaternary structure to link in protein structure and function. So in sickle cell anemia, one amino acid, which is valine, replaces the glutamic acid on the beta chain. And then you have your globulin chain, which is your polypeptide over here. You have your 4 heme groups, each which contains an iron, an Fe iron, which is going to actually attach to the oxygen. And then also CO2 is attached to nitrogen and amino acids in the globulin. Right, so this is the structure of a 4 subunit, 1 hemoglobin molecule. Here is a normal red blood cell. You can see it looks like a donut with the thinned center, and this is a sickle cell anemia. Just from the flip-flop of this one amino acid, it causes the shape differential because now the protein's not going to fold correctly. And this looks like a sickle, which is like an old kind of sword thing. It's a sickle, C-shaped knife. And so this is what sickle cell anemia red blood cells look like. So in this figure, this is the effects of the sickling, and this is figure 10.17 in your book on page 202. And so you have your red blood cells that are going to be the hemoglobin is independent of oxygen. And normally, like I said, these are flexible discs. But when the oxygen levels are low, the red blood cells sickle, and then they become elongated and rigid. And then as the blood circulates through the body, the oxygen levels decrease. And the erythrocytes sickle, and they're therefore unable to pass easily through the small arteries. And then the cell membrane is damaged. The red blood cells have a shorter lifespan. And so this can lead to an occlusion of small arteries, which is blockage. And so then this can lead to tissue damage and multiple infarctions. This is very painful and it can cause loss of function. And then over here, you can also have the increased red blood cells in the spleen. So that's hemo is blood, lysis is splitting apart. So the increased breakdown of the red blood cells. And also then that would cause the decreased red blood cells, therefore causing severe anemia. And then this can cause hyperbilirubinemia. Oh my God. Hyperbilirubinemia. And that would be, in normal words, jaundice. Okay. And so this shows the occlusion of the arteries, everything that happens. Okay, so think of this. So our blood vessels, our veins, capillaries, arteries, all that stuff, they're round. Okay, so normally we have a little round red blood cell go through. So sickle cell can be very painful because, if you think about it, again, you're going to be, little sickles. And so have you ever like snagged a nail and it's instead of being round, there's like a little edge on it and then you kind of cut yourself like that? You see how painful it is where normal nails are fine. It's the same thing with your red blood cells. When they're shaped wrong and they're shaped like a sickle, not only do they get caught on things, they have a propensity to gather then and form like a blockage, but they're going to be bumping up along like the cell walls of your vasculature system and instead of flowing nicely. So that can be very painful. So you have multiple infarctions that can affect the brain, bones, and organs. And in addition to basic anemia, you have hyperbilirubinemia, jaundice, and gallstones, and these can be caused by the high rate of the hemolysis or the breakdown of those blood cells. Clinical signs do not usually appear until the child's about 12 months of age. Signs and symptoms are going to be severe pain because, again, either the blood cells aren't getting to the cells or to the tissue itself and it's causing ischemia or slow death of the tissue, as well as it can cause an infarction. You can have the pallor, the weakness, the tachycardia, the dyspnea. You can have hyperbilirubinemia, which again is jaundice. You can have splenomegaly, which is an enlarged spleen. You can have vascular occlusions and infarctions, and these can occur in your lungs, and these can cause acute chest syndromes, and these can also occur in your smaller blood vessels, and one example of this would be your hand-foot syndrome. Since you're not oxygenating all your tissues correctly, this can cause a delay in the growth and development, and this can also cause congestive heart failure. So what do we use for diagnostic tests? Well, we are going to do red blood cell or blood smears, right? So when you look at a blood test, you can determine the abnormal red blood cell morphology or the shape of those red blood cells. You can also do hemoglobin electrophoresis, and you can also screen prenatally to see if your child potentially is going to have sickle cell anemia. How do we treat this? Well, this is on page 202. And so we are just continuing to try to find more effective drugs, but the use of hydroxyurea has reduced the frequency of crisis and prolonged the lifespan for many, but it's not effective for all. Also, we need to make sure to supplement your dietary input with folic acid, which is also known as folate. This is to do all the time, even if you're not having symptoms. And you also want to avoid strenuous activities or high altitudes so that you don't tax your blood system. Other preventative methods would be prevent dehydration, acidosis, infection, or exposure to cold, which can all increase the sickling tendency and cause painful crises. Children also should be immunized against pneumonia, influenza, and meningitis, and continued prophylactic penicillin may be necessary for the groups of young children and adults with severe cases. They're doing gene therapy investigation to see if we can try to fix it at the genetic level. Bone marrow transplant is effective, but because of the limited number of African American potential donors on the bone marrow registry, it can be very difficult to find a match. So in the past, the patients rarely lived past their 20s, but now, because of improvements in cares, they've extended their lifespan into middle age for many influenza, or I'm sorry, many patients. So if you guys remember TLC, salt and pepper, right? One of the bandmates back then, actually she's still alive, but she has it. I think it was T-Bones. I know I totally just slaughtered that, but anyway, it's very prevalent. So here is a comparison of selected anemias. This is page 203, table 10.2. So you're talking about your iron deficiency anemia, precocious anemia, aplastic anemia, and sickle cell anemia. Then your characteristics of the red blood cells, your etiology, as well as additional effects. So this is a great little summary table to maybe make a flashcard over. So what about indications of blood clotting disorders? These are started to be discussed on page 204. And so basically, if you have persistent bleeding from the gums, this can be one of the symptoms of it. You could have repeated epistaxis, TK, which are pinpoint flat red spots on the skin and the mucous membranes. You can have a frequent purpura and ecchymosis. These are more than normal bleeding in a response to trauma, and also bleeding into the joint, which is hemophysioarthrosis, and this is swollen, red, and painful, and also hemophytosis. And so, there's a nice little orange box that says warning signs of excessive bleeding and possible blood clotting disorders. So again, persistent bleeding around the gums and teeth related to or repeated nosebleeds. The petechiae, which are those spots that results from bleeding from a capillary or small artery. The frequent purpura and ecchymoses, which are your large purplish, red, or greenish areas on the skin or bruises. The most persistent bleeding warranted from a trauma, bleeding from a joint, coughing of blood, which is the hemoptysis, and this would be the bright red flecks in the sputum. Vomiting blood, which is hematemesis, and this is often coarse brown particles that kind of look like coffee grounds, and they may be red. Also, presence of blood in the feces, anemia, etc. So this summarized in that table. And again, feeling faint and anxious, low blood pressure, and rapid pulse. So this is an example of what those petechiae, those little spots, can look like, and this is figure 10.19 on page 204. So you can see it's just like spotted little, they look red spots here. All right, so what about hemophilia A? This is on page 209. And so this is known as classic hemophilia. It's a deficit of the abnormality of the clotting factor 8. This is shown in figure 10.9 if you go back to it. It's the most common inherited clotting disorder. 90% of hemophiliac patients have type A. The defect causing hemophilia A is transmitted by an X-linked recessive trait, and therefore it's manifested in men, but it's carried by women who are asymptomatic. With improved treatment and longer lifespan for men, this pattern could change. An effective man and carrier woman could produce a child offspring. All right. So basically, you can have varied degrees of severity, prolonged bleeding that is going to persist after minor tissue trauma, spontaneous bleeding into your joints, and then possible hematuria or blood in the feces. So how would we diagnose these? This is on page 205. We are going to measure bleeding time and PT, and those should be normal. Then the PTT and the activated PTT, which is the PTT, as well as the coagulation time is going to be prolonged, and the serum levels of factor 8 are low. How do we treat this? Well, we, of course, are cautious, and treatment with the desmopressin, which is the DDAVP, may rise the clotting factors in some patients. And then the drug stimulates the endothelium lining of the blood cells to release the stored factor 8. And then the replacement therapy for factor 8 is also available for like IV administration, and it's especially useful before surgery or dental procedures. But interesting fact, hepatitis and HIV have been transmitted through blood products. This is more in the past. They screen for them now. And blood now is treated to destroy the viruses. So the some risk remains, but not very much. Okay. So what about the leukemias? Um, so the group of neoplastic disorders that involves white blood cells would be your leukemias. Trying to find this. Hold on a second. I'm going to pause for a second. Okay, leukemias are found on page 208. And so basically, leukemias are a group of neoplastic disorders involving the white blood cells. And the estimated number of new cases of leukemia is between 31,000, and this includes 2,500 children. And of these cases, 11,000 are lymphoid, 15,000 are myelogenic, and 5,000 fall into other categories. The overall survival rate is about 45%. Awesome. So basically, leukemia involves white blood cells, and this is causing uncontrolled white blood cell production in the blood in the bone and lymph nodes, and other hemopoietic tissues can be reduced. One or more types of leukemias are undifferentiated, immature, or non-functional, and then you have large numbers that are released into the general circulation, and these can infiltrate the lymph nodes, the spleen, liver, the brain, and other organs. Okay. This is a summary table of the leukemias, and this is on page 209, table 10.3. And so this is the type, the cell that's affected, and the age group that it affects. The summary of acute leukemias, which would be ALL and AML, these are a high proportion of non-functional cells in the bone marrow and the peripheral circulation. The onset is usually abrupt, and they have marked signs of complications, and these occur primarily, again, in children and younger adults. The chronic leukemias, which would be the CLL and the CML, these have a higher proportion of mature cells, but with reduced function. This has an insidious onset, and mild signs and better prognoses are there, which is great. And these are common in older adults. This is an example of a blood smear of ALL, which is acute lymphocytic leukemia, and this is on page 209. And you can see the blood cells here as well as the purple guys. And so these are common in young children, and so the blood smear is going to show the smaller lymphocytes and normalitic anemia. So the purple guys are the lymphocytes, and the little red donuts are the red blood cells. So what about signs and symptoms of acute leukemia? Well, usually the signs at onset are frequent or uncontrolled infections, those spots, the petechiae and purpura. The signs of anemia are also present. You would have severe and steady bone pain, weight loss, fatigue, and possible fever, enlarged lymph nodes, spleen, and liver. And also you could have headache, visual disturbances, as well as drowsiness and vomiting. So how do we diagnose these? So this is on page 210. So basically, we would use peripheral blood smears to show the immature leukocytes and altered numbers of white blood cells, which are usually generally increased. A high percentage of the white blood cells are immature and they appear normal, and numbers of red blood cells and platelets are going to be decreased, and also the bone marrow biopsy is going to be used for confirmation. How do you treat it? Well, chemotherapy is the way to treat it, and some types of leukemia, such as ALL in young children, do respond well to drugs, and prognosis is excellent. The best prognosis is actually found in children between 1 and 9 years of age. Infants and adolescents respond less positively to chemo. Also, biologic therapy with interferons is also used. And this can be used to stimulate the immune system to help protect itself again. All right, some complications from leukemia would be opportunistic infections, including pneumonia, sepsis, congestive heart failure, hemorrhage, liver failure, renal failure, and CNS depression and coma. So that wraps it up for today, you guys, and have a great day, and I'll see y'all in class.